Good morning, or good afternoon, huh? It's already, yes. All right, team, should we go ahead and start? Those of you who have heard this lecture will be largely similar to what we had last year, and this will be a test to see whether you remember anything from the last year. With that, the first question that I will be asking you, which again, I hope to make this interactive with you all, is what is the most significant impact of genetics? You can choose for one of the multiple potential impact of genetic discoveries and tell me what you think. Do you think is the best for preclinical diagnosis? Do you think is best for pharmacogenetic-based treatment, risk stratification, or individualization of therapy, or do you think it is something else? If you get that question for me at the end of the talk, I have given you my message. And that will be the key message of today's talk. What is the real impact of genetics in practice of medicine? So with that, this beautiful model you see here is an art. It is an art of nature. This beautiful model won the Nobel Prize for Dr. Kornberg when he discovered it. And it practically is the essence of life. This molecule determines why we are so similar. It determines why we are so unique and different. This beautiful molecule is DNA polymerase, responsible for replicating the genome. The task of this molecule is to replicate 3.2 billion units of DNA, which is what our genome is comprised of. We are diploid genomes. We have 2 copies of each chromosome, each gene, one from mom, one from dad. Each is about sorry, did I push something or was it just on timer? Each has 3.2 billion units, so 6.4 billion units in the nucleus. And the function of this DNA polymerase is to replicate that. It replicates about 20,000 genes. The genome has about 20,000 genes, which genes have coding regions that are code for proteins. They are referred as exons. There are about 180,000 exons. The size of the exons referred to as exome, that is about 30 million nucleotides. So if I ask you a question, what percentage of the genome codes for protein? What percentage of the genome is comprised of coding regions? Guess. 1 is correct. So if you look at the numbers, you can see 30 million, 3.2 times 10 to the power of 9, 1% of the genome codes for protein. How about the rest of it? What about the 99% of the genome? What does it do? Is it junk DNA? Is it just DNA with no functions? So there are a lot of regulatory elements in the genome, and more than 100,000 regulatory elements in the genome. And there are also non-coding RNAs. Not all RNAs have to code for protein. There are a huge number, maybe over 100,000 non-coding RNAs in the genome as well. Could any of you give me an example of a non-coding RNA that you probably have heard a lot these days? You heard about microRNAs. that people use it as markers for myocardial infarction, marker for coronary artery disease, or involved in pathogenesis of the phenotypes. It might be, but in general, microRNAs are definition, are small tiny molecules of 22 units of nucleotides. They bind to the 3' and translate of the region of the RNAs and regulate translation of the RNA to protein, typically inhibit. I consider them nudgers and microtuners. They are tiny regulators of the genomic function. But genome contains huge number of those. At least several thousand have been described, but there are also long ones, long non-coding RNAs, which are several kilobase, several thousand base pairs. The function of those are largely unknown. So genome is an exceedingly complicated structure. This is just the DNA component of it, and genome is wrapped into proteins, which are histones. Histones get modified through different functions, such as methylation, such as acetylation, such as phosphorylation, and that affects gene expression as well. And collectively, they regulate all the biological processes that we talked to. The function of this beautiful enzyme, the function of this magnificent protein that is wrapped around this DNA is replicate the entire genome. And it does an amazing job. I yet to meet a fellow or a postdoc or a resident can match the performance metrics of this DNA polymerase. This beautiful structure can put 100 million units of DNA together and does one mistake. You try to do 100 million caths and have one complication. Is an enormous beauty of the nature. The accuracy and precision of this DNA replication machinery is unbelievable. One error every 100 million nucleotides. And that error is the entire determinant of why we differ so much and why we are so unique. Why someone responds to small dose of beta blocker and develops fatigue and forgetfulness. The other one takes 240 milligrams of the same beta blocker and does without any significant side effect. This is the main reason for inter-individual variations, whether it is variation in the color of eyes or color of hair, or variation in response to drugs or susceptibility to disease. So this translates to, if our DNA replication machinery does one error of every 100 million units that put together, how many new errors are going to be introduced with each genomic replication? Every time you have a baby, how many new DNA errors are you going to introduce in addition to those that were inherited from you and your wife or husband? There will be 30 to 50 new variations, new polymorphisms, new variants, DNA sequence variants in every child. So your child will differ from you by 30 to 50 nucleotides. So if you genotype your child and it's 30, 50 nucleotides is different from you, do not get ideas. So that also, in the bigger picture, if you think about this and you say there are 30 to 50 variants are introduced in the genome pool, which every child born, what would be the impact of it in this society? First fascinating point of it is, if you're going to have a child, you better have it early in life. Why? Because the error rate of your DNA polymerase goes up as you get older. This beautiful slide illustrates this point. This is the age.
Doctor, it depends if you like yourself too much.
And if you look at the age, and you look at the number of new variants introduced in the baby, increases significantly. So if you are a father at age 40, you have twice more likely to introduce variants than if you are a father at age 20. Now that explains why generation is moving toward teenage pregnancy. No. It's fascinating. And then, if you want to vote, you have 50% chance to be correct. Variations come mostly from dad or mom?
Mom. Of course it
My
was
God,
mom.
you are sexualists. What do they call them?
Feminist.
Oh, not feminist, otherwise. Discrimination, what do they call? Yeah. Oh, yeah, sexist, thank you. No, vast majority of the de novo variation come from sperm. Because sperm is the one that replicates. And therefore, every time replicates, introduces one error into the pool and gets transmitted to the baby. Ovum does not replicate, it's fixed already. So yes, vast majority of, so fathers are responsible for diversity of the mankind, not the mom.
It's coming from a man, I don't know if you can see that.
So, and also older fathers are the main culprit. The youngers are less likely to introduce mutations. Another fascinating aspect of this is this. If you're a father at age 20 and you give a variant, which is in your sperm, to your baby, as compared to your father at age 40 and give another variant to your next child, the baby that is born when you were 20 is less likely to have the variant in the so-called important component of the genome, in exons, in protein coding regions. If you are 40, it is more likely your variant to be a pathogenic variant that is affect potentially protein structural function. And this is empirically shown in this data. This is intronic or intergenic. This is exonic. Naturally, as you all appreciate, we discussed earlier, 1% of the genome codes for protein. So the number of exonic has to be very, very small. There's about, as shown in this graphic illustration, there's about 30% enrichment of potentially pathogenic variants as you get older. Interesting, in de novo variations. The new variations we're only talking about. So anyway, that was a little bit of fun talk. So the nature of these variants, each has two DNA strands, one from mom, one from dad. And as you know, DNA is complementary base pairing. C always binds to G and T binds to A. These two copies of DNA, one from mom, one from dad, they differ. One is CG, the other one is complementary nucleotide is TA. This is called a single nucleotide polymorphism or single nucleotide variance. Each one of us about 3.5 million of those in our genome. So, but they are not the only variants. There are variants that are, this is 2 chromosomes, these are 2 loci. Here you can appreciate one loci is duplicated. Here you can appreciate the loci is missing. Here the loci is inverted or a new locus, homologous recombination, converted the chromosome, has made some rearrangement, and here in this particular case an insertion. These are called insertion deletion polymorphisms or structural variations. If a structural variation affects a copy of the gene, or copy of the coding, non-coding gene, could be RNA gene, that is called copy number variant. How many of those we have? Thousands. Now brings the fascinating evolutionary component of human genetic variation and our survival. Of course, we all originated from when God created us. He landed us in Africa. In Africa, we went south, we hit the ocean. We went west, we hit the ocean. Finally, we made our way wandering around toward north, to Mesopotamia, to Middle East, from there to Asia, Southeast Asia, finally crossed toward Alaska, Bering, crossing, and down to Alaska and North America around the border. So this didn't happen overnight, happened over billions of years. Didn't happen as a continuum, happened intermittently because glaciers and others destroyed human famine, and they came back next generation, next wave. Finally, we made it. But what happened? We were growing very, very slowly from billions of years ago, very slowly. Something happened here. The last 400 generations, our population growth exploded. Who can tell me what was the main reason for explosion of the human population during the last 400 generations? Agricultural revolution. What happened? We started learning to cultivate, start learning to feed ourselves. So the 400 generation ago, the population exploded. So each chart introduces 30 to 50 new variations to the genome pool. And you have this enormous explosion of population during the last 400 years. What does that mean? Enormous amount of the new genetic variations introduced during this era, right? Each person introduces 30 to 50. And those 30, 50 variants, because they were introduced just recently, they have not been able to spread in the population, right? Therefore, they are rare, they are uncommon, often they are unique to the individual. On the other hand, a variation that occurred very early on in Africa was shared as the generation gradually moved out of Africa towards Mesopotamia and Asia and Americas. It was shared, passed on generation to generation, is an ancient variant, and therefore it is a common variant because it passed along to everybody else. Everybody has it. This is a common variant, this is a rare variant. New variants are rare, old variants by definition are common. So, one more aspect of this important observation is this. If a variation occurs here that makes a person blind, and the dinosaur is chasing this guy, he will be extinct. The variation that has a large effect size, and if it occurred early in evolution, it was a common variant, would have been extinct. Only those that had minor effect sizes didn't make the person blind, made them have maybe a little myopia, let's say, but didn't make a significant clinical impact, survived. But here, a person might have been blind, but did not have enough dinosaurs to eat them up, has not been subject to evolutionary pressure here yet, because a new variation. And that takes usually generations. I mean, I'm using the example of dinosaur to be silly, but evolutionary pressure takes generations to eliminate the bad gene and maintain the good ones. So a lot of variants that might have occurred here potentially could be bad variant, have not been excluded yet because of evolutionary pressure. But those bad variants that occurred millions of years ago probably have been eliminated too, largely because of evolutionary selective pressure. So what does that mean? It means this is empiric data. These are not hypothetical. These are now with massive, the technique of massively parallel sequencing of nucleic acid. You know all these numbers. Here, about 2,000 people were sequenced. This is population data. 86% of the variants that were identified in this pool were rare. Not only rare, they had allele frequency of less than 0.5%. Of 1,000 individuals, 5 individuals had that allele variant. 86% of the variants were rare. Isn't it amazing? Of course, This was novel. The novelty depends how many more you sequence. Ultimately, you'll find some. But this is interesting part of this is this. And of those variants that were identified in the population, you say, okay, let me look at those that change amino acid structure, those that change protein folding, protein function, deletes the protein, introduces new sequences to the protein. It does mess up the protein. It's called pathogenic variants. What percent of the pathogenic variants in the population are common? What percentage of pathogenic variants, variants that potentially could cause disease or biologically significant, are rare? 96% of the variants that have potentially clinical significance or biological significance are rare variants. It doesn't mean you may not find a common variants that doesn't cause clinical phenotype. In cardiovascular, we don't have very many, but you might have heard about famous ACE, angiotensin converting enzyme insertion deletion variant, which accounts for 50% of the variability of the plasma ACE level and contributes to various pathological phenotypes that are associated with angiotensin 2 production. Likewise, in kidney, however, there's a variant in a gene called ApoL1, apolipoprotein L1, that is a common variant, robustly associated with various forms of kidney disease, from glomerulonephritis, non-diabetic chronic kidney failure, hypertensive kidney failure, and so forth. There are common variants, not routine in the population, but that potentially have clinical significant impact, but they are rare situations. Vast majority of the variants that have clinically impactful effect are rare variants. So let me ask you a tricky question. Are rare variants more common than common variants? Right? Think about that. The statement is true, but the rare variants are more prevalent in the population than common variants. Twisting the fact that makes it a little bit easier for you to appreciate. This is another fascinating part, which is very much relevant and very much fascinates me about clinical trials. And you know, clinical trials now truly are international clinical trials. Seldom a clinical trial is done locally or in a single country. It's all international. But these genetic variations truly follow geography. You go to Italy, somewhere in the map there, you will find different, and this is color-coded based on frequency of the variants in the population. Let's say pick up certain variants. Italians have a different genetic imprint, genetic structure, genetic architecture than, let's say, you know, Britain or Scandinavians, or even Spain and Portugal. Look at this is the map of Europe, color-coded based on frequency of the alleles. It's amazing that allele frequency looks like similar to map of the Europe, despite the fact that we all consider Europe relatively homogeneous population, relatively speaking. Imagine US. So the point of being that there's a lot of variation in the genetics that are geographically determined. Now, of course, with migration and everything else is becoming less of an issue, but the point is population is specific. The variants that I have are likely to differ from variants that you have, and so forth. And we didn't know much about the extent of this variation in a single individual genome. That was population genome. How about me? And this distinguished, crazy young man, exceedingly brilliant and exceedingly arrogant. This is Dr. Craig Venter. He is the one, back in 1990s, about NIH-sponsored programs in the country, universities, about 13 different institutions doing Human Genome Project. Large scale sequencing, and it was taking a long time, and it was taking a lot of money. Craig Venter was part of it. He got fed up with it. He said, you guys are a bunch of bureaucrats and, you know, academicians that are wasting taxpayers' money. He got out of it, and started his own company and decided to sell it at that time. John knows all about it. He was a major investor at that time. And so he decided to sequence the genome independent of NIH, as just single individual, basically. And practically speaking, he did beat NIH investigators. And he sequenced the entire genome in 3 years. NIH investigators took about 13 years. And the cost of his sequencing was less than 10% of the NIH money spent on sequencing. So we didn't know much about it until, and then, of course, they have to politically have it correct, so they invite him over to White House along with Francis Collins, and President Clinton announced that now the first draft of human genome is available and so forth for June 6, 2001. But anyway, this crazy guy sequenced his own genome. And it is mesmerizing to find out that he, as expected, we didn't know at that time, he had 4 million DNA sequence variation that differed from the rest of us. Of those, 3.2 million of them were at single nucleotide. He had a lot, at that time, 1/3 of them were novel, because, as now more sequence has become, the numbers have dropped. He had about 1 million variations that are referred to as, remember I said more than single nucleotide, that gene duplicated, gene inserted, gene inverted, gene insertion, deletion, variants. Half of his genes, the 2 copies of genes that he has, half of them were not identical. They differed. 44% of his genes. Well, that's the reason he's crazy anyway. And he did this by this technique that we refer to Professor Frederick Sanger. Those of you know who apparently was an exceedingly distinguished person. I never had a chance to meet him, actually, unfortunately. He died, it's not present, I should correct that. He died last year. Professor Sanger won 2 Nobel Prizes. One for describing the structure of insulin. He was the first one to do that at protein level. The second one was very elegant technique that he developed for sequencing the DNA nucleotide. He color-coded the nucleotide, but rather than the nucleotide, he changed the nucleotide to a little bit different. So when DNA synthesis occur, dideoxynucleotide, he put that in there, a little bit of structure of change, color-coded, so that dideoxy got incorporated, the chain was terminated. So you can, at that position, that nucleotide should have been C. At the next one should have been. So he developed this method which by electrophoresis you can detect. And we all worked on this. We used to work, all day, and maybe took about 5 days to generate 250 units in the small labs such as mine back then. But that was the basis of human genome sequencing, this method. But the world had changed, and this is the way, by the way, we used to do. And look, the 2 copies of DNA are identical. You see 1 peak at every spot. Unless here you see 2 peaks, one from mom, one from dad. This is called single nucleotide variation. So that's what we used to do. Now the world had changed to what is called massively parallel nucleic acid sequencing. The technique of that, you fragment DNA into millions of pieces. Each is about 200 to 300 base pair. And 100 copies of those simultaneously are sequenced by various methodology that exist that either labels it or terminates it or adds some chemical to it that you can detect it. So each strand gets sequenced 10 times, 20 times, 30 times, and you can appreciate sometimes, because it's a mixture of 2 copies, one from mom, one from dad. Here, these both at this position, this is C, whatever, G, or the next one is A. So there are copies of DNA in this pool of sequence that sometimes is A, sometimes is G. So it's a polymorphic for that position. Now this is the way it is done. This is an amazing, powerful technique. You practically can sequence every single person's exome in a few days in the small laboratory. And of course, bigger laboratory, much different. And everybody's genome in 1 week, which is 3.2 billion units in 1 week. You can do it in a small lab if you have the right machine. Costs about $1 million to set it up, to sequence those. But it's moving. The field is moved from sequencing a small laboratory. Actually, we spent $1 million in my lab, set up this instrument, this actual product of that. And basically right now is a doorknob. We don't use the instrument anymore because competition has become so difficult. The companies are we generated this sequencing particular one cost us about $4,500 to sequence one exome. Now you can send to companies, they sequence it for you, less than 1,000. So it's not competitive. So we shut down our operation, we just send it to commercial sources to get it done. Everybody's doing that way. The same way you don't know how your sodium, potassium, electrolyte, cholesterol is measured, this is becoming the same way. You will send out the genome, and indeed we do that genetic testing. I will discuss that a little bit. And the results comes out, and your job is not really know the technical aspect of it, the same way you don't even know how sodium is measured these days. But you got to know how to interpret low sodium, high sodium, and so forth, the same as DNA sequence variations. To sum up this part, introductory component of this talk, each one of us have 4 million variations, 3.5 single nucleotide. Of those 3.5, in addition to those, we have about 10 to 100,000 structure variation, copy number variations. Of these variations, about 12,000 of them change the protein structure. They are called non-synonymous variants, which means amino acid change from amino acid glutamine to alanine, for example. And of those, maybe thousands of them are potentially damaging. They can damage the protein function. This is based on in silico algorithms, so we don't have biology for all these variants to know. Each one of us about have 300 variations, 200 variations that has affect function of the protein and protein function. At least one of the two copies is non-functional. And we are missing about 20 to 30, or we have non-functional proteins, 20 to 30 non-functional proteins, each one of us. And we totally missing about 3 protein every single one of us. What are those of the 100,000 proteins? Who knows, but we each missing some. All right, and here is Professor Watson, who was sequenced here at Baylor College of Medicine. This is an amazing discovery too. And also links to clinical significance. How do you interpret these findings? It's an exceedingly challenging task. Professor Watson, in addition to all these common variations that we discussed, like Dr. Ventner had, he has one copy of a recessive mutation, in mutations that are known to cause recessive disease in human population. He is heterozygous, at least as one of the mutant copies, for 11 different diseases. It's amazing. But despite that, the guy is, he's politically incorrect, but he is free of those diseases. It means that makes a challenge. How do we take that genetic information and apply it at the bedside? Can we do genetic risk stratification, genetic-based diagnosis, genetic-based treatment? The essence of all really boils down to this distinguished Sir William Osler. He truly understood, despite the fact that genetic didn't exist, this statement truly reflects that. The good physician treats the disease. The great physician treats the patient who has the disease. And that's the essence of the genetic, because every single person has his or her own disease. No two patients truly have identical disease based on the background genetic information that I gave to you. Let us take quick examples of the opposite end of the spectrum and say how we can take the genetic discoveries and apply to practice of medicine. On one end of the spectrum are diseases when those rare allele, rare variant, when it occurs, the effect size is enormous. Child or patient or the young individual get the disease. Here I picked up a single one, excluding congenital heart disease, that a little bit perhaps might be complicated because there are multiple genes involved, segments involved. Here is a single gene disorder, hypertrophic cardiomyopathy, which is a rare disease, relatively 1 in 500, 1 in 350. It's an uncommon disease. And this is caused by rare variants. This is because 350 in the population couldn't be a common variant that has half of the people have it. So therefore, it has a rare variant. But the effect size of that rare variant, clinical effect size of it is large because of the disease, if you have that variant. The other end of the spectrum, here is a thrombus sitting in a coronary lumen, is a atherosclerosis, which is a common disease. Common and rare variants both contribute to pathogenesis of atherosclerosis. Effect size of each one is a little bit small. Let's take an example of hypertrophic cardiomyopathy. One of the first impact of genetic discoveries is accurate diagnosis. This particular distinguished patient was treated as hypertrophic cardiomyopathy for years. And here is the mitral leaflets. You can appreciate they're a little bit thicker than usual, but nonetheless they're hanging out there. Septum is quite thick. There should be a unit here somewhere if you can see it. And this patient, when autopsy was performed on this patient, had this storage disease. Had nothing to do with hypertrophic cardiomyopathy. This was a Fabry disease. Of course, today we can do enzyme assay, alpha galactosidase, and measure level, find out. You can do genetic testing to find out. But it's not simple. I have now an active patient who is a physician, by the way, which I strongly believe he has Fabry disease, but he has a rare variant, which is rare in GLA gene, but is not known to cause the disease. His enzyme in 2 measurements were 0, in 1 measurement at a different institution was a little bit less than normal. Does he truly have it? Some people who work in Fabry, they totally say, no, he doesn't, because he has only isolated heart disease, nothing else, no other component of Fabry. It ain't simple. But nonetheless, it might help to accurately diagnose these cases. What was the name of the mayor of New York that answered the phone and said, I missed that. Remember during election time last season? Giuliani, right? Answered the phone, wife, I'm here with firefighters. Then he didn't get the vote. Don't you remember that? Anyway. So, it is estimated that about 10 to 15% of clinically diagnosed hypertrophic cardiomyopathy is the wrong diagnosis. Interesting. And I deal with hypertrophic cardiomyopathy all the time. I swear to God, at the end of the day, it's true. I actually saw one today. I could not convince myself it's a true hypertrophic. By definition, it is. But you never know. Truly, you never know. We all look alike. I mean, it's very hard to know. So, the second impact. This is a real story as well. This was a young lady in Kentucky, so forget that accent, was jogging and died sudden cardiac death, unfortunately. This sister came to us, told us the story, and more importantly was worried about her son being at risk, and there's family history of sudden cardiac death. So genetic diagnosis, this was mostly through, here you can appreciate the evidence is a little bit strong. This person we had the DNA from had a mutation that arginine had changed to glutamic acid at 791. Likewise, affected person, unaffected people did not have it. They had the normal variants, and affected one had it. Likewise, the child had the variation. But phenotypically by EKG and echo was perfectly normal. So it's a mutation career. So what do you do? With this risk of family history of sudden cardiac death, genotype positive, phenotype negative, do you intervene? What do you do? We really don't have treatment for this condition to prevent it. Do you put defibrillator in a kid that has a variant but no clinical symptoms? Do you look at Richard? There are rare cases of patients that had hypertrophic cardiomyopathy mutation and died without showing evidence of hypertrophy. You worry. You don't know. Nonetheless, we opted to follow up. 3 years later, the kid had hypertrophic cardiomyopathy, clinically diagnosed. EKG showed up, echo showed up. He had indication of hypertrophic cardiomyopathy. Now we say, okay, he has hypertrophic cardiomyopathy. He has risk of sudden cardiac death. 3 family members. A mutation that in the literature associated with risk of sudden cardiac death. Do we go put a defibrillator on, or wait for symptoms? It's a risky situation. Nonetheless, we opted to wait for a while, and then one day, father came. Before that, one day father came, said, by the way, he was playing soccer. You know, kids at that age all play soccer and baseball and so. He college didn't look good. Father was dentist, his dentist. I know he was, and so he didn't look good. It just took him out of the game, and So we did at that time evaluate. I said, look, I mean, you know, symptoms, pre-syncope type of symptoms, mutation, family history of sudden cardiac death, expressed cardiac hypertrophic cardiomyopathy. Let's put a defibrillator. With some hesitation, procrastination, which is natural to every father. This young kid got a defibrillator on, and then a year later or so, father brought the kid back. So this device shocked my son, and it's very annoying, very disturbed, very, you know, the kid is terrified. And he was very upset because he thought it's an inappropriate shock, which of course, you know, often is the case because you don't wait to faint and then shock, you know. So interrogation showed that this kid indeed had VFib. So what, did genetic have any impact in being more aware of the situation? I don't know. Maybe it did. Maybe, you know, we could have done the same without genetics. Who knows? But increases awareness. Let me take the other end of the spectrum, coronary artery disease. Coronary artery disease is typically mapped through a type of studies that refer to as genome-wide association studies. You take 5,000 cases with coronary artery disease, 5,000 control, you genotype them for 2 million variations in the genome, compare the frequency. Which one is more common in cases, which one is this, as simple as that. And they plot them, you plot them around against the chromosomes, chromosome 1 to 21, and sex chromosome not included, 22 is so small. And this is your threshold of significance. Anything, each hit is a polymorphism, a SNP variation. And those that are significant, this particular one is notoriously significant, has been reproduced 200 times. Is it a specific mutation, in a point mutation in 9p21 locus. That indeed, when it came out, some companies start genotyping and selling. Physicians, let's genotype your patients and tell them the risk of coronary artery disease and so forth. Well, vast majority of the variants that have been identified in the genome for complex diseases such as coronary artery disease, they do not affect the protein. They are in intergenic regions. Very small fraction affect this color, affect the coding region. Rest of this doesn't change protein. This is an intron. This is between the genes. This is somewhere in non-coding area of RNA. Where are the proteins? None of these mapped genes, mapped variants for coronary artery disease affect protein structure. So how do they cause the problem? So GWAS, that's a major deficiency in that regard. It maps a locus for you, and that locus could be something called linkage disequilibrium, which means a block of chromosome that always segregates together. So whether you mapped it here or gene is here, you don't know. So it shows you the area. It doesn't pinpoint the exact. So are they clinically significant? So when this company came and said, let me really genotype you and tell you risk of coronary artery disease, and epidemiologists are master of that. They have nothing better to do. I have an editorial that I'm waiting to come out because I love the first sentence in that editorial, and that's it. The first sentence, it says, if epidemiologists were compared to fishermen, the truth is a very hard fish to catch. It is elusive. Anytime claim to its capture ends up being false, and stuff like that. It's a weird, I didn't make that statement. I quoted from somebody, but it has, it's still not out yet. But I'd like to see that one. Anyway, so epidemiologists immediately don't do any fundamental research anyway. So they're out there, let's do people genotype them, find out risk of coronary artery disease. So I said, okay, let's look at this famous locus. These two are mapped. Look at the p-values. That's what the statistician and epidemiologist. Look, 10 minus 57. 23% increase in risk of coronary artery disease, 16% increase of risk of coronary artery disease. Therefore, we can genotype individual. Indeed, one company was genotyping. You know, the Berkeley laboratory that does extensive lipid profiling, that included in their profile back then. And here is the raw data, where those numbers come from. This is one of the original studies back then. If you look at this particular variation, they are the same variations largely. If you look at this variation, this SNP, if you look at 12,000 control, this variation is present in 49, is that 48 or 49? 49% of them. If you look at cases, this variation is present in 55% of them. This odds ratio is gone up by 25% increased risk. This is 95% confidence interval of it. P-value is very significant. This is the basis of that. And my response to this is this. Those of you who are old generation, the only one here is really John. The rest of you wouldn't know this. Old days in 1970s, we used to go around, I'm not that old, but nonetheless. We used to go around and look at people's earlobes. You have earlobe crease. Your odds of coronary artery disease, 2.7-fold. Risk of sudden cardiac death, 3-fold. So would you do 9p21 or just go around and look at the earlobe crease? For you to ponder. And this is also the same for all complex diseases, or hypertension, for example. How many of you measured the blood pressure on your patients yourself? You must, that's really, I mean, don't rely on nurses, they don't, oh, sorry. Actually, to be honest, I never get it twice within 10 millimeter mercury of each other. I always measure 3 times without exception. Often 3 times, and I cheat, measure 1 time on the other arm or 2 times on the other arm. But it is, look at the effect size of this. This is the largest gene, genetic variation. This is the gene, the variation in the gene that is associated with hypertension. Increases the blood pressure. Systolic is in red, diastolic is in blue. 0.8 millimeter mercury. Diastolic 0.4 millimeter mercury. I can't get it within 10 millimeter, let alone 4. All of them, without exception, within that range. Lipids is not that different. If you can read it, look at the effect size on LDL. Where are they? Here. You know, 0.94 milligram per deciliter reduced total cholesterol, 2 milligram per deciliter, 1 milligram. Oh, you know, this is with an error of measurement. So distinguished men and women. Yes. So the effect, the significance of the genetic risk factors in terms of individualizing, oh, you are at risk of this and risk of that for complex disease is practically nil. You're wasting your time. How about pharmacogenetics? The best one studied is Coumadin, anti-oral anticoagulants, because there's enormous variability in response to Coumadin, which is a pain in the neck to figure out how to adjust the Coumadin dose. Every day it changes. Pharmacogenetic-based approach versus clinical-based approach, they are basically superimposed on each other. No significant difference. This is not the only study. Few studies have done. So my distinguished colleagues, I'm going to ask you the first question that I asked at the beginning of the talk. So if genetic for complex disease, such as coronary artery disease, hypertension, dyslipidemia, has minimal clinical impact in terms of diagnosis, risk stratification, or treatment. Despite our distinguished President Obama saying precision medicine, those are biopoliticians. So what is the impact of genetics? Whoever gives me the right answer, anybody? I don't have any money. Whoever gives me the right answer, this is to fool you. Just, oh, must be this complex way of analyzing, figuring out multiple genes together, genetic risk score, this and that. They're all pure nonsense. This is the real impact of genetics. Whoever tells me what it is truly will get a glass of wine on me. This is the real impact of genetics. John knows this. He has invested heavily in this. He has become multi-billionaire because of this drug. Let me give you a clue. That was discovered based on genetics. A family with autosomal recessive or dominant hypercholesterolemia with MI, carotid stroke, and lipid deposit on the skin.
It's a new medication, PCSK.
Professor, what else left? Excellent, brilliant. So this was the gene for this disease was mapped to this locus. This is the linkage evidence. This is logarithm of odds, which is 5 means, 1 in 100,000. The gene is here. This was the mapped area. PCSK9 was mapped. Mutations were identified. This was what? 2003. And you know the rest of it. You know that today we have 2 drugs that are exceedingly effective in lowering LDL level, an enormously lower level, might be even dangerous, so low. That's the PCSK9 inhibitors. That's the real impact of the genetics. It is not to tell, by the way, you are at 10% increased risk of coronary artery disease or that disease. If the likelihood of that disease is 1 in a million, 10% increase was not going to make any difference. So it depends on many things. So this is the story of it. I'm not going through these slides. You guys, you know this very well. Despite treatment with statins, on top of it PCSK9, and do an enormous, amazing job. But that's not all. PCSK9 was mapped through conventional Mendelian disease genetics, families, segregation, linkage analysis. But you're dealing with diseases that often Mendelian pattern is not there. Often familial aggregation, it is there. You have a family history, oh yes, X family, this, but you really don't have, you can't put them together to link to something. And there is always a family history. Don't ever write there's no family history. There's family history. There's no family history of premature MI maybe within 2 generations or so. But the other power of genetics, which is in the same line, through GWAS type of studies that I was ridiculing a few minutes ago, saying the effect size of these are 1 milligram change. This is here. John, can you see it? Do you see anything called SORT, sortilin? Oh, there it is. This one? How much it changes LDL? 5 milligram per deciliter. That drug now is becoming the next PCSK9, if you ever figure out. So the power of that, so don't get fooled by my comments telling you that, look, genes affect the LDL, HDL, or cholesterol level by 1 or 2 milligrams is irrelevant. No. It gives you pathways. It gives you new molecules to target. This sortilin gene, I never heard of this nonsense protein ever. Oh, sorry. This sortilin was mapped through GWAS, the one that affects LDL level 1 or 2 or 3 milligram per deciliter. Now, people are working out the mechanism to figure out how it affects ApoB level, and that will be the next PCSK9. John, company, invest immediately. Yes, sir, yes, sir. Yes, sir. You have it under control. I don't know who makes. My point is, the power of genetics is the summary slide. It provides a fundamental insight into mechanism of the disease. And if you do that, then you cover LDL statins. How were they discovered? They discovered by Brown and Goldstein working on when they were at NIH training. They met this young kid who had FH with cholesterol of 500, 600 and dying from premature coronary artery disease. And when they moved to UT Southwestern, they got fibroblasts from those kids. And that's what they were studying from a single case. Then they added a couple more cases later. And they find that the mechanism involved inability of these fibroblasts to uptake cholesterol. There must be a receptor for it. They did find them. When they find the gene, the rest is statins are history. The same, the power of genetics, which was my question, is not being a fortune teller, telling people you're at risk of MI or this and that, although epidemiologists like that. The power is in making fundamental discoveries that will lead to identification of new drug targets, new treatment for human diseases. And that's the essence of genetics. And that's the only message I wanted you to get today. Thank you. End of the dictation. That comes certainly the Mosley statement.